Thank you. Good afternoon, everyone. So let me motivate this a little bit. So, you see a talk on process improvement. It's not the most interesting thing in the world. And, why do we do it and what the purpose of it and why the timing is now. So if you look at where we are in imaging, we're at this place, especially in North America, but you see it now in many other countries as well. We're at this phase where imaging has kind of come to its point through its clinical capabilities, through its improved diagnostic capabilities, but is now at a transition where it's really quite ubiquitous. And the next level is, how do we make it much more operationally effective? How do we make it much more productive? How do we improve the quality of the care and integrate it into the larger systems that we're now a part of? So radiology is a piece of a much larger piece of activity that's going on. So if we look at specifically in the US, we're in this sort of triple aim, quadruple aim world where we're simultaneously trying to improve the care, the outcomes of the patients, the quality of the outcomes, the patient and staff experience, at the same time, the cost, right? Cost being a fundamental driver more and more these days. So how do we balance all those out? And the other sort of big activity that's happening now at the same time is the rise of data. So all of the data that we have access to now, how do we use that data to empower, to be able to drive this grand optimization between outcomes, cost, and quality? So let me begin a little bit with really where we are in imaging today. And I think these are really the challenges that we're facing. So first of all, volumes in imaging, contrary to popular belief, are still growing, and they're actually growing faster than population. So it's still rapidly growing, and I think it's because of a lot of the real diagnostic outcomes that we're now showing in imaging. So it's important to emphasize that's in the backdrop. Second point is, over the last 30 years, the number of data points that we're using to make clinical decisions has increased 100-fold. And so imagine now, as physicians, as administrators, you're trying to make clinical decisions, but now really being, bombarded with all this data. And by the way, our brains haven't really expanded to be able to deal with that kind of information. So we need to have systems and processes in place to really go after that issue. The third bullet that you see there is, we're more and more moving into a value-based reimbursement system, maybe not 100%, maybe not even 20% in some institutions, but this is really creeping up on us. One example of that in radiology is MACRA. So right now, if we look at the MACRA metrics, which is the way physicians are getting paid, about 125 metrics are being candidates for MACRA for all physician types. 25 of those, which is a pretty significant number, are radiology-based performance measures. So measures that are going to now do pay-for-performance type payments for radiologists, let's say over the next 3 to 5 year period. So we have to start preparing to collect that data to be able to drive those kinds of performance improvements. Down here you see the workforce burnout issue. This is a very, very real issue. Radiologists are among the top areas for physician burnout, and I think it's really motivated by all of this and all the change that's going on in the system. So we have to really focus very much so on radiology and staff experience in order to improve outcomes as well. The last two, and I think these are really the big financial problems, if you will, in the system. So if we look at the radiology as a business practice, and I'll just take the United States for example. We spend $120 billion in imaging in the United States with a B, and about $100 billion of that is acquisition of the images, and that's that split that you see here. And about of that $100 billion, $12 billion is the equipment. So the rest of it is operational. So out of the $120 billion, $86 to $88 billion is operations of radiology. And that's not sustainable, especially with all the pressures that are coming in. So how do we start to drive a system that can help automate certain things, drive the operating costs out, reduce the cost per exam, while improving quality and outcomes? And the last one is really about the waste in the system. So again, out of that $120 billion, an estimated $12 to $15 billion is waste, what I would say waste. So repeat testing, unnecessary testing, tests that are an hour long that can be done in 30 minutes, tests that are 30 minutes that are done in 15 minutes, wrong tests at the wrong time, imaging test without contrast when a contrast should be given, all those things, just because we don't have controls in our business processes to drive that optimal outcome. So what we're trying to do from a Philips perspective is see these challenges. How can we really help our customers and radiology as a discipline evolve to address these needs? So I think the first thing is we start to now take a really systems level view to radiology. So what I mean by that is traditionally we have the two pillars of radiology, which is I have my informatics and interpretation, which is sort of this part of the workflow, and then you have the acquisition, and that's again what you see traditionally. If you look around the floor, these are the areas that we're really emphasizing also historically in the RSNA. But there's this whole continuum from scheduling and preparations to acquisition to the diagnostics and interpretation, report communication. And again, the radiologist of the future is going to be much more than a report writer. They have to really start communicating, participating in the shared decision making. And then outcomes and follow-up. So I'll give you just one very basic example. 10% of all radiology exams that we do have a follow-up recommendation. Who's accountable for that follow-up? Right now, there isn't anybody in the system that's totally accountable for it. There's a lot of handoffs in the system. So we got to start taking a systems level view if we're really going to drive radiology into sort of the next decade and a half, the future of where we are. The second concept I want to sort of illustrate here is right now, we put technology between the patient and all the providers. You go to the MR console, what do you have? You have a big MR system, intimidating, patients are in there, technologists are outside the room. There's this barrier that we're creating in all of the things that we do in the world. So idea here is, as we now think about how does that new system look like, that integrated system, really building technologies and artificial intelligence and various capabilities to move technology around that patient-provider relationship. Can I enable things on the scanner to automate protocoling so that the technologist can be directly interfacing with the patient most of the time, and a lot of things are going on in the background, and they're having more patient face time, and really driving better quality outcomes. Well, why is that important? Patient experience is a big issue, but in MR, 70% of all repeats is patient motion. So if I can have that contact, assure the patient of what to expect, we've seen now through our data that repeats are going down. Quality of the imaging procedure is going up, right? So there are all these things that we have to really start thinking about in a systems level way, and that's really the way that we're now developing. So as I said, we have the traditional modality silos and the traditional informatics silos. Now, looking at it at a systems level, what we've now built is what I would say is the third leg of the radiology stool, if you will, which is operations and performance improvement. So PerformanceBridge is our performance improvement operational analytics platform with services, and that's what we're now introduced last year at the RSNA, and this year we're expanding on that offering. And really what it allows us to do is combines very deep operational analytics capabilities, so pulling data in every step, as you saw, of the workflow, providing a consolidated view of that information, and then people services, benchmarking services, best practices services to drive and deploy process improvement in your departments. Because we see that tools alone are not sufficient. We need to sort of bring that gap of the people. So I've had, we talk about this all the time, I have people tell me 85% of this problem is data, but 85% of this problem is people. And you have to start to bring the data and the people together in order to drive the performance improvement. And that's really what our solution's about. And we focus on a couple of different areas. So we focus on, the idea is not everybody wants to do the whole system. So we've also, let's say, deconstructed performance improvement. You can do it around assets. You can do it around services. You can do it around, am I utilizing my resources the best way? We then have a more comprehensive solution, which is the whole practice, that end-to-end that I showed you, all the turnaround times, all of the follow-up tracking information, all of the repeat scans, so really being a much more comprehensive solution. We also have compliance things like dose. Are we delivering the right dose? We see other compliance things coming on forward, which is, another example is radiology has a lot of accreditation data that they have to pull together every time JACO comes in or what have you comes in. So can I help you manage that data from an accreditation perspective, all the compliance elements there around that as well. And of course there's the people element. So can I craft specific training programs for my technologists to help them get better in their areas of weakness? Can I help radiologists peer learn from each other through best practice reading? So we have really evolved our peer learning capabilities on the radiology radiologists in the PACS kind of areas, if you will. But also operations-wise, front desk worker, how do we bring, let's say a mission briefing at the beginning of the day to plan out the whole day? How do I enable tools to give that view, right? So, if you go and walk through our floor, we have a concept of mission briefing, which is, can I get all of the EMR data, all the data around the patient before I begin an interpretation? Well, why aren't we doing that on the operating floor? Why am I not seeing what my whole day is going to look like and helping plan that in a daily stand-up? And then now I'm running a business practice, an operations practice that's now really optimized, and I know where the challenges of the day are going to come from, right? So really getting to that level, and that's where you can deconstruct it and get pieces, or we can put the whole thing together and drive a whole system level operation. So the areas that we're working in, and maybe just to give a couple of examples, the idea is you have analytics capabilities to do various metrics. There's basic metrics that you're already tracking today, which is volumes and so forth, but they're derived metrics. So one of the examples that we also are now tracking are what I would call repeat and low value images. So one example is radiologists put in their report many times, here's such and such, difficult to read, I had an artifact in this area, or motion blur caused this effect, and I can't make a conclusion. So we're able to now, through native natural language processing technologies, extract that information and quantify in a particular modality, in a particular type of exam, what the low value imaging rate is, what a repeat imaging rate is. And so through that, drive various improvement activities. Follow-up tracking, I mentioned that briefly. Follow-up tracking is a really interesting problem. It's actually one of the future macro compliance metrics. And it's alarming what's going on in that space. So about 10% of all radiology reports have a follow-up recommendation, meaning you have this disease, come back in 3 months because we want to do another MR exam or CT exam to figure out where the disease is. Do you guys want to guess, in most institutions we work with, what's the actual follow-up rate when it's recommended in a radiology report? It's 1 in 2. So half the time, patients aren't coming back. And it's across the spectrum. It's happening as much in very serious diseases like oncology follow-up, where they're very critical. It's happening in lighter areas where maybe orthopedic follow-ups, where people have taken discretionary measures. So how do we drive that improvement, right? How do we drive that into the workflow? So we have now follow-up tracking applications which can extract that information from the radiology report, provide it to the scheduler, providing to the referring physician as an aggregated data set, provided to, let's say, your telehealth staff so they can maintain the continuity of care with those patients, especially if you have a specific service line type of function that you're trying to drive. So really that's the other element I want to emphasize. Let's also bring data into radiology to drive better radiology performance, but taking data out of radiology into the other parts of the system to drive overall better care. And a lot of that is built, and how we built our system to be very open, to be integrated with EMRs, to be integrated with different PACS systems. It's really a multi-vendor capability that we've developed. And as you now identify these problems, it's great that you know what's going on, but how do we then now drive an improvement? So if we know now that we have a high repeat rate, as an example that we found out is in a department they had a 25% low value repeat rate in their neuro MR exam types. And then if you do the root cause analysis, it was because they had 4 MR magnets, one of them had an inhomogeneity which was causing an artifact, but 4 of the techs knew how to fix that, one of them didn't. And so whenever that one tech operated that one scanner, you had a low quality image that was happening every single time. The department had no clue this was going on for about 3.5 months. And now you have a system to surveil that. And so what we went back in and fixed the scanner, tweaked the service issue, retrained that tech on that specific artifact correction, and the rates dropped down to less than 5%, right, within that 2-week period where we deployed that technique. So these are the kinds of things that these systems are now allowing us to do. And again, a combination of analytics and the people-based services and improvements to drive an overall better value in the system. And just to kind of finish out, the types of data that we're looking at analytics-wise, we talked about follow-up recommendations, but we have patient scan times, exam times, uptake, which is a big issue in nuclear medicine, tracking that in real time, so I can now, in the operations environment, show real-time wait time information, and then suggestions for routing patients when they're waiting too long. So the technologist knows, hey, that patient's been waiting 35 minutes, that MR scanner doesn't have a scan for the next 15, slot that person in. So automating that sort of control on the operations side is something that we're doing. Bringing digital whiteboards to interventional labs so they can manage their lab environment, not through dry erase boards, but track all the steps in the flow in an IR setting. And then you have also a lot of revenue cycle stuff that we're now starting to track as well. So to get to that idea of what's your total cost, what's your total revenue. And again, I think a lot of the historic work in operations is focused on how do I become more efficient in productivity type of measures, but now we're getting into the quality space. But the other element to look at is how do I manage my referral network? What's going on in my referral community? So also looking at the revenue side or the input streams, where are my service lines growing? How do I adapt my resourcing accordingly to do that? Obviously we're doing PQRS metrics, but maybe one other area that I want to emphasize is image quality measures. So we now have technologies to extract motion blur information, artifact information, wrong positioning information from the images themselves. So you have a diagnostic radiology, an X-ray film. We can tell you where the positioning was not wrong or incorrect or correct, and give that sort of in an analytics view to go back in and do retraining of staff so that they can start to get better quality images from a more objective perspective as opposed to a subjective perspective, which you see in the reports. So a whole host of areas that we can drive improvement in, and you start to put it all together, you start to go after that $12 billion, $15 billion waste issue. You start going after driving the cost of operations down so that the staff can start to really focus on clinical care, clinical quality, clinical outcomes. So let me pause there and stop and see if there's any questions. Thanks for your attention. I hope it's a chance for you to come and see, hey, an area that we're really investing in, and right in the center of the spine, you can come in and see some of the specific tools on the PerformanceBridge portfolio as well, and potentially how we can bring some of that to you.